All right, gents. Well, in theory, the blue bar is going across the screen. All right, I believe we are live streaming into Workplace. You guys are good to go.
Hey, thank you, Ashley. Appreciate it. Hey, DSN, how are you all doing today? Today, we have another clinically based surgical webinar with our Studley founders over at the Colorado Surgical Institute. Today, we have Dr. Taher Dune and Dr. Dan Brisky talking about sinus lifts and demystifying and hopefully simplifying this procedure, which many people would consider complex and intimidating. And they're going to talk you guys through exactly how they instruct this over at the Colorado Surgical Institute and how they handle these types of procedures in their own private practices. So without further ado, my great friends, Dr. Dan Brisky and Dr. Taher Dune. What's up, guys? Let's talk sinus today. That sounds like a good plan.
How's it going, man?
You made that sound like a very sexy topic, so now I'm very excited to talk about it.
I make everything sound sexy, Dan.
So I guess just to start off, sinuses in themselves, it's case selection. When you're getting into this, it's all about your case selection to see if it's going to go easy or uneventful, or if you're going to encounter some certain levels of complexity to it. So first and foremost, what we encourage everyone to do is if you have a case and you're unsure if it's easy or not, what we do for all the Colorado Surgical Institute alumni is we do conference calls with them, or you can send us pictures of the case and then we can just talk it through, because before you even start a case, it's going to be very important to determine, is this one you should be doing, or should you be referring it, or should you do a traditional bridge? With that said, I'll kind of hand it off to Dr. Brisky. I know you're going to kind of run the PowerPoint on your end.
Yeah, for sure. So yes, let us keep you guys safe when it comes to doing surgery here, like when to refer, when not to refer, and when to start pushing the envelope as you feel comfortable. I think what Dune and I feel very passionate about is not sending cases to the specialist and needing to be bailed out. So let us definitely help you guys. So let me put this one up there.
So what we're going to be kind of chatting about today is verticals, or that crestal approach, versus a lateral approach, and kind of when you need to graft, when you don't need to graft, what materials to use in the sinus, different things to ask patients before you get started. And then if you guys have any questions that you want us to specifically address, just drop it into the chat and we can absolutely address it for you guys too.
Yep. So a new patient comes through the door and you're deciding what to do and how to treatment plan this, right? And this is how I treatment plan it. I'll pull the CT up. I'll measure the amount of bone that I have from the crest to where the sinus is located. Now, if that distance of bone, if you have 2 to 4 millimeters of bone, I would recommend a lateral sinus. If you have 4 to 7 millimeters of crestal bone, I would recommend you doing a vertical sinus, right? So you can do the implant at the same time that you're going to be doing the sinus lift. And this method, there's a lot of different kits. So we're going to go over some of our favorite ones and which those are. Now, if there is 7 to 10 millimeters of bone, you can just place the implant. I think a lot of people are very surprised by that. I get a lot of fight back. They're like, well, what if this? I'm like, no, it's not as complex as we think it is. Surgery, we've all been taught to be very scared when it comes to the sinus. Like, oh no, the sinus, the infamous sinus. Don't look at it, right? It could blow up on you. It's a little bit more friendly and forgiving than people give it, especially if you have a healthy sinus and you place your patient on good medications, you're using the right technique. You're not blown through past the sinus when you're placing this implant. So I'd say with that rule, if you have 7 millimeters of bone, and when I say 7, not 6.5, right? So I think a lot of the time when we're doing the surgery, we tend to hide our eye a little bit. So, if that will, for example, if you're going to place an implant and the width of that bone is 6 millimeters, well, should you squeeze it in or should you augment the bone, right? It's the same thing with the sinus elevation and placing an implant. So I'd say it has to be like a firm 7 millimeters, maybe 7.5, not 6.5, right? If it's 6.5, do a vertical sinus, keep yourself safe.
And if it makes you feel more comfortable in the beginning and you guys do PRF in your practice, just go ahead and just, if it's in that 7 to 10 millimeter range and you just want a little bit of more a safety net, put a little PRF up in there in the beginning and then just follow with your implant. The PRF will kind of tent the Schneiderian membrane up a little bit, and then your implant can follow and you can feel a little bit more comfortable.
Yep.
Can
Agreed.
you talk through that? Can you talk through that PRF strategy a little bit? So you're creating the PRF. Let's just assume people know, the procedure to do the PRF, and then you have the little the little flattened membrane, PRF membrane. How exactly do you put that into the socket, and are you using your vertical sinus kit in order to get that up there?
Either use the burr of the last, use the implant burr, the last size that you use to push it up, or you could use one of those bone condensers. I know Dune uses a bone condenser, I think, in his practice. He has it's like a little stainless steel, comes in 2 different size widths, usually like a 3 and a 5 or something. I don't remember the width, but
Looks like
you
a
can use a
really
bone
long,
condenser.
thick, looks like a really long, thick periodontal probe.
Yep, exactly.
So what I'll use in mine is I have like the Blue Sky Bio sinus lift kit. And so let's say my entry into the sinus, like the antral floor, is going to be 8 millimeters away. I'll set my stopper on it because these kits have stoppers on them. I'll set the stopper at 7 millimeters. So it's 1 shy of the depth I drilled. And then when I put the PRF up in there, I can ensure I'm not over condensing. I don't accidentally slip and then tear the membrane. So I put a stopper on when I'm pushing anything into the sinus, and I'll push it in 1 millimeter shy of my drill depth.
Mm-hmm. Yep, agreed.
Thank you.
So
Thank you.
let's go through a couple cases of where you just place an implant. Okay. And I think we all have these in our practices and we start to shy away from doing these ones. So for example, like this case, typical molar or premolar case, right, where the sinus just dips down a little bit. This is at least 25% of cases look like this in terms of research. So if you have that 7 millimeters bone, literally just place the implant. So what I would do is I would drill. So this is a neodent implant. It has a deep conical connection. It's meant to be placed 1 millimeter below, right? So if I'm going to be drilling here, you're going to be drilling until you hit the sinus floor, but you're actually going to be drilling past it. So you're going to be going an additional 2 millimeters into the sinus, because what will happen is when you go to drive the implant in, the implant can spin once it hits the cortex where the sinus is, and then your implant will have no stability. So an implant like this, you have to place it bicortical, which means you're going to have cortical engagement, right, on the top of the osteotomy and on the sinus floor.
And just for clarity, when you pop into the sinus floor with like a 2.0 drill, sometimes that's not going to be wide enough of a hole for the apex of your implant to engage, and it still can bottom out and basically auger the bone out of there. So sometimes you got to get your 3.5 in there. But if your bone is too soft, sometimes what you can do is just push your 3.5 in or run it at 50-50 in terms of, your RPM and torque. And then you can just lightly pop into the sinus at a bigger diameter of your osteotomy. So then your implant can go and get your bicortical stabilization.
Yep. And if you look at that picture on the left, I really loved using guided burrs with burr stoppers on them. So if you have 7 millimeters of bone, grab the stopper burr, comes in an 8, 10, 11.5, and a 13. These are Blue Sky Bio ones. I still have a set of these tucked away in the closet if I'd like to use them. But use them because it's smart, right? If your sinus is at 7, grab your burr that's 8. But that burr that's 8 is actually 9 because you have the extra millimeter on the tip of it, right? So if you put the burr all the way down, you're going to be exactly to where your location is going to be. If you grab too big of a burr, right, like 11.5 or 13, and your hand slips, then you're going into the sinus, 5, 6, 7 millimeters, which is not good. So we do want to be precise and only be prepping the bone where the cortex is. So if you're going to be placing 8 millimeter implant here, with an 8 millimeter implant, neodent, you're supposed to place it 1 below. So you need to be prepping to 9, right, in order to screw the implant in. So how I would do this is I would first take a lance burr in, like a sharp one, maybe a 1.5 or a 2, go in maybe 4 millimeters, 4 or 5 millimeters. And then make sure you like where your placement is. And then you can take your 2 millimeter with a stopper, and you're going to be going all the way down to depth with that. And a lot of time, if you're really curious on where you are, I would, at this point, after you drilled to about 5 or 6 and you're going to switch your burr to the pilot, you can drop your speed down to 50 Newton centimeters at 50 RPMs. And the burr is going to just rotate down like this, and then it's going to hit the sinus floor and it's going to stop. So that's going to be your landmark. You're going to say, oh, cool. Well, that's where I am now. I know I'm at the sinus because my burr stopped. It's not going to go past that cortex. Also take an x-ray to confirm where you are. Then you can actually advance the rest of the burr all the way down because you're doing it in a controlled fashion.
Right.
And I would avoid going any more than about 3 millimeters into the sinus. So just prep it enough. And like Dr. Dune said, 2 is not wide enough. You'd probably need to go to about a 3.5 millimeter burr. And that's if you're placing a neodent, which a lot of us are. So I'd say 3.5. And then you're going to be prepping the rest of the osteotomy on the top of it. So you could take your, if you're placing a 4.3, prep to the 4.3, maybe down to about 8, maybe a little bit less, and then put the implant in.
And whenever I'm doing implants, I'm typically under prepping the osteotomy so I can get as much stability as I can. And then, Dr. Brisky already covered it. You're getting bicortical stabilization. Now, when you're placing implants and you're going subcrestal, what you may notice is you start going subcrestal and you start losing torque. Typically speaking, when that implant, the apex of the implant starts engaging the antral floor, the sinus floor, you'll start to feel the stability come back in, right? But at the same time, if you're in a very like D4 soft bone, environment, you may want to consider leaving the implant at the crest of the ridge, so you're truly getting stability at both cortexes. Because sometimes you drive it too far down, you start losing a lot of stability. And it's maybe not a place you want to be. And then the pros of being equicrestal outweigh the pros of being subcrestal.
Yep. And if you're feeling shy on this one and you put the implant in and you're really still a little bit unsure of where you are, like if you really prepped into the cortex, really watch out for when you place in the implant. Because if you're placing the implant and you notice the implant quickly loses the stability or it starts to turn, you have to immediately recognize that. Because if it bounces off the cortex and starts to spin, it can churn up all the bone. It's just like a shovel, it just churns it, and you're not going to get stability either way. Because that 4.3 millimeter one's going to turn into like this huge circle where you're going to have to place like a 5 or a 6 just to get stability. So definitely watch the movement of the implant when you're placing these to watch out if you quickly lose stability. So this is another case. This one was a really good day at the office where those 2 crowns on the left were splinted. So I had to section it, and I also had recurrent decay. So this treatment plan was a crown buildup, and then a vertical sinus, or actually a crown buildup and extraction, bone graft, membrane, and an implant placement. Right. So good day at the office. And I think Dune and I these are probably an hour and a half visits to 2-hour visits. So very, very productive morning.
Any tips on that root canal tooth out of the socket without damaging the buccal plate?
Yeah, of course. So with this one especially, I sectioned it first, right? And I really like using either a straight forceps or an ash forceps. I think that's really helped me become a little bit more precise. And you can also, don't be afraid to elevate a little bit from the lingual. I do that commonly a little bit more often now. So if the buccal is really thin, elevating a little bit more from the lingual with a good elevator. And when I say good elevator, I like to use something that's an luxating elevator. So something that has a little bit of a sharper tip on it. So you're not kind of crushing the interceptal bone or placing undue pressure on the buccal bone. But when you're taking these teeth out with a forceps, I like to use an ash forceps for this. And I'm really just doing like rotational movement. I'm not doing buccal lingual movement when I'm doing it. And I'm putting my finger, usually I'm right-handed, so I'll put my pointer finger on the buccal bone and the lingual bone, and I kind of just support it. And then I take my ash forceps and I kind of do a rotation, more of a rotation movement rather than a buccal lingual. So I see a lot of plates fracture when there's too much of a buccal lingual rotation.
Yeah, I agree with everything Dr. Brisky said. The only thing I'll add to that is look at your CBCT, see if there's, bifurcated roots, see if the buccal bone is already thin. That way you kind of know what you're getting into before you start. And if there's bifurcated roots, go ahead and section it early. And that way you can just preserve as much bone as possible when you're getting into the surgical component.
I
Great tips.
rarely tell patients that I'm going to do an immediate implant. I kind of set them up a lot of the time to tell them it would be amazing if we could do that implant for you the same day. It would just be a bonus, but I don't ever guarantee it, because when I do guarantee it is usually the one time that it doesn't work out for me, right? When you take the tooth out and the buccal plate's attached to it. So get in the habit of not telling patients you're going to do the immediate.
Yeah. Manage expectations for sure. I'll say a version of that. I say, hey, 90% of the time we place the implant at the same time. If it's not absolutely a perfect scenario, we're going to go ahead and put a bone graft in and wait. And it doesn't change the cost either way. And I say a version of, if I can be, I want to be as respectful of your time as possible. So if we can place the implant at the same time and shorten your surgical, duration of how long you have to come see us, that's what we're going to do. And every patient's usually on board with that approach.
Yeah. And I'll also show the CT, like a cross section of the CT, and show them how thin the bone is. So what I'll commonly do is I'll throw up CT and I'll take a pen and I'll kind of outline where it is, or use the mouse cursor and show them, hey, this is the tooth and then this is the bone. Your bone is about the thickness of 3 sheets of paper, is what I usually say. Then they're like, what? That's crazy. And I'm like, yep, don't worry, it's normal. Everyone's is like this, but that thin piece of bone can break when we take the tooth out. So they find that a little bit a good analogy. So this one, yep, was an immediate, and it's just engaging the sinus here, right? And I think this bone was this one was 9 millimeters, almost 10 to where the tip of the implant was. So let's talk about sinus elevation kits. Now, about a month ago, Blue Sky Bio discontinued mine and Dune's favorite sinus kit that both of us have used for probably 6 or 7 years now. So it was a very sad day. We had a little funeral ceremony for the sinus kit.
Poured out a 40 for it.
Yeah, poured out a little bit for our homie, the sinus kit, right? So it was a sad day. So this started me thinking, man, what am I going to do to tell people to use, what kits to use in the future, right? So we are going to be trying to work with Neodent to make a kit with them. Hopefully that works out. So possibly, not possibly, we're not sure right now. But we do have some kits, right, that are still available. And unfortunately, our gold standard is not available anymore, even on the black market. So if you have one, good, protect it. If not, we gotta find you guys a new solution here. So there's a few different main types of kits out there. This kit to the left, this is Blue Sky Bio's new kit, right? But it's just their guided kit. Their guided kit has been around for, I think it's been 4 years now. And they're just rebranded as their universal sinus kit, right? And there's nothing wrong with it. It's just, for me, I can't get as high of a sinus lift with it. And we'll explain a little bit about that later. The kit on the right, this one's by Hyacin. Hyacin has a Crestla kit that is pretty good one. I like it. It's more of hydraulic, so it's going to use water pressure to lift the sinus kit up, or lift the sinus floor up. Another one here is on the left. This one's made by JK Dental Studio. This is a pretty simple kit. All you're doing is, we'll explain this one a little bit, but all you're doing is removing where the bone over the top of the sinus, and you're going to be using a bone putty, like Novabone, to do it. And then there's a kit on the right, which is osseodensification. So it's Versa. Also, not my favorite type of kit because I think the complexities increase. You can have implant failures, and we'll talk a little bit about that as well. So Dune, what are you advising people to use these days as far as kits?
I think my general bird's eye view statement is always whatever works best in your hands to get the results that you're looking for, use that. Now, in my hands, it's going to be the Blue Sky Bio Kit. Granted, I've used it a lot. I've used the Versa before. I've never used the Hyacinth kit. I've used JK's kit before, and I like that also. But with the Blue Sky kit, I just get really predictable results. I like it that has a stopper system on it, so then it's more controlled, and I like teaching on it more because when our attendees come in and they use that kit, they are less likely to tear the membrane, and when they go home, they're less likely to tear the membrane. And even if it does take maybe an extra 5 minutes, maybe extra 10 minutes to use the Blue Sky kit than some of the other ones, I just think it's more predictable for the stoppers and for the ease of use, and they last a long time. Like I've had my one kit for 6 or 7 years and it's still, just, steady the whole time.
Yep. So with this new kit, there are stoppers, but the stoppers are only with the burr. They used to make these little stoppers that go on top of the burr, and you can select the size based on the width, but now it's just one burr and one width. So a little bit different, but still possible to do the lifts. So, and this will be one of those cases. There's 4.2, maybe a little bit more, maybe like 4.5 there. So not under 4 millimeters. Otherwise, you're kind of risking a perforation here because you're going to be going a little bit too high. I've found with the Blue Sky Bio Kit, I'm successfully getting between 4 to 6, I think would be a really good rule of thumb in terms of your sinus elevation. Really anything more than like 6 millimeters, it gets a little bit more sketch. You could have some perforations. So at that point, you may consider doing a lateral sinus.
And then also, I think the CT is a good example of one that is ideal. It's just nice and bowl shaped. It's even. You're going to want to look at your CT in all angles, right? Your axial, your coronal, and your sagittal, and just really see it from all angles to make sure there's no like little septum hiding somewhere. There's no slope that's occurring, because it may measure 4.2 with one view, but you got to look at it in your X, Y, and Z axis and just make sure that there's no slope where it's actually 6 somewhere. And then you're, keep drilling and you don't understand why you're not getting through the sinus floor. Sinus floor.
Cool. So strategy on this kit is this Blue Sky Bio Kit, the tips are neurosurgery burrs. So they're meant to cut bone, but it won't cut the tissue, which is pretty cool. So you can see there's a range of sizes, and they all start in the width of 3.6. So in the beginning, when you're using these burrs, you still have to create an osteotomy, right? For that burr tip to go into. So when you're doing that, you have to be very careful not to slip and send your burr right all the way through the sinus. Then you have to wait a very long time so you can try this again. So I would recommend, right, if you're going to use a pilot burr, just go in 2 millimeters. Okay. And then if you're going to grab your next burr up, which can be a 2 or like the 3.5. So if a 3.5, the tip of a 3.5 burr is not 3.5. It's like 2.3 or 2.6. This burr is a straight. So the tip is actually 3.6, right? So if you're going to start your osteotomy with a neodent, let's say, I would do a lance burr into the osteotomy by 2 millimeters. And then I would take a 3.5 in about 2 millimeters, because that's going to extend it to about 2.8. Then you might be able to, you can probably fit the tip of this sinus kit burr into the osteotomy now, right? Because you're going to be only, right, because it's about 3.6. And they come in all different sizes. So we got 2.5, 3, 4, 5, 6, 7, 8, 9, 10. So let's look at this kit, this one. So 4.2 millimeters, I'm going to take my burr in 2 millimeters with my lance. Then I'm going to take my 3.5 and take it in another 2 millimeters. So now it's at about 2.8 maybe 3. Then I'm going to grab one of those crestal sinus burrs here, and I'm going to pick the size based on how many millimeters there are. So if there's 4 millimeters, our goal is going to be to pick one about 1 millimeter short. So for this circumstance, I'm going to grab a 3. And when I put the burr in, you're not going to be drilling high speed, like a 1600 or 800 or 2000. You're going to be drilling slow. So you're going to be drilling at 50 Newton centimeters at 50 RPMs. And that burr is going to basically just wind itself down and stop. It's going to stop when the stopper hits the bone around it, right? Like right here. So when this stopper is going to hit the bone, it's going to bottom out. And it's not going to be able to advance any further. So if it bottoms out and the stopper's even with the bone, we know that we haven't drilled far enough, right? So what you do is you increase by 1 millimeter increments. So we're going to grab the next size up. So after the 3, we're going to grab the 4. We're going to go in with the burr. And this time we're actually going to put the burr in, but we're going to press in. The reason we're going to press in is we're looking for that burr that's now 1 millimeter longer to be advancing. If it advances, that means that we're in the sinus. If it doesn't advance, that means we still have bone that is over the top of the sinus floor, and we still have to remove that bone in order to get to the membrane. So then you kick on the pedal and you go 1 millimeter further. All right. Then you take that burr out, you grab the burr that's the size up, that's a 5 millimeter height, and you're gonna do the same thing. You're gonna put the burr in and you're gonna press in, and you're looking to see if the stopper right here advances. If it does advance, that means you're in the sinus. If it doesn't advance, that means you're still on bone. So if it doesn't advance, you step on the pedal and you're at 50-50, and it winds it down and it stops. Right? Then you're going to do the same thing. You're going to grab your next burr, take that one out, put the 6 on, and put that burr in. And one of these burrs, whether it's 4 or 5 or 6, it's usually about the 5 or the 6 that I see it, a little bit higher than what you usually predict, because this bone is curved right here, right? So what if your osteotomy was right here? It's going to go up and it's going to elevate at around maybe 6 or 7 sometimes, because it could be up here. But if you're smack dab in the middle, then it's going to elevate at about 5 or 6. So now we're at the stage where we removed bone, and we think we're at the level of the sinus. So now I'm going to put the 6 in, and it has a stopper. And when I press, it actually goes down all the way. That means there's no bone because you just drilled it away with those sinus burrs. So now you are into the sinus. So this is what we're looking for. And at this point, I do see I would not drill anymore, because you're at your final width already. Your final width is usually going to be that 3.6. Your final height is accomplished now because the bone is gone. So now we're going to be relying on us packing bone and pressure to raise the sinus floor up. Those packer burrs right there, they are meant to condense bone, but they're not meant to go into the sinus. So if you look at those instruments there, the double-sided ones, they have a flat apex, but it has a corner, it has a 90 on it, so it's sharp. So I wouldn't be taking that into the sinus, right? You're going to be taking it into the osteotomy. And Dune, you want to explain a little bit how you do the bone condensation?
Yeah, and so what I'll do is I'll pick from a bone condensation. Actually, I'll take a step back. When you feel like you're through the sinus floor, the antral floor, I'll have the assistant put the surgical suction on it. I grab a mirror. Literally one of the only times in surgery I grab a mirror, and I like to look up the osteotomy. If you see like pitch black, you might have torn the membrane, because then there's this little layer of membrane and tissue that's torn, and now you're seeing into the empty cavity of the sinus. But if you see like this little bit of fluctuance in the tissue, and once you see enough of these, you'll know. It's hard to kind of describe, but then you'll know kind of, hey, the membrane's still intact. And then when you go into your stoppers, yeah, I'll pick a stopper. Let's say in this scenario, it's 4.2. I breach at a 4 or a 4.2 or a 5. I'll pick a stopper at a 4. So that way my stopper's always in the osteotomy and I'm never going to slip or over condense material and tear the membrane. Also, sometimes when you're pushing material in your osteotomy, it won't push vertically. So sometimes this like little rotational movement that you're going to be doing to move the material, whatever type of biomaterial you're using into the sinus. But what that's also doing is condensing, it's widening the osteotomy. So let's be aware that that's happening as well. But it's also condensing the bone in your osteotomy to some degree. So I'm always condensing one short. Typically, I'm going to draw, ideally, 6 to 8 PRFs if I'm doing a sinus procedure. If you're only doing one single implant, maybe draw 4, that should be okay. And then I'll try to get a PRF up there. Usually if it's a really nice slug, I can't get the full membrane up into the osteotomy. So I have to cut it into, 4 pieces or cut it in half or just kind of squirts in and out. And I'll start with PRF and I'll usually try to get 2 good sized slugs up inside the sinus, then followed with cortical cancellous or any type of like allograft or autogenous if you harvest it, or xeno, but I don't think xeno is really indicated in a vertical approach. So I'm usually using the maxius bone, the allograft bone, after 2 slugs of PRF.
So Dune can get way bigger sinus lifts than most people, right? Because he's done them for about 7 years. So he's comfortable putting, maybe 2 slugs into the sinus. In the beginning, we advise you to put a half of one. So I would actually just cut one in half. And you can take a little cotton forceps, just put it over the top of that area, and then you can press it in. Now, how you press it in is decided upon how much bone you have. So in that case, it was probably 4.2. It probably went through at about 5. So I would take that stopper, that's a 3, and then I would press the PRF in. And then I would take the stopper, that's a 5, and then I would push that in. The reason, just like Dune said, if you're pressing, you could, with the 5, you could actually go like this by accident. Whoops, right? You could have this very firm apical pressure, which is not what we're looking for, to condense something into the sinus. We're not looking for a quick, swift like pressure in. We're looking for like doing a little circle motion and gently making that PRF go into the sinus, right? So I first go in with the 3 like this, just kind of move it around really slowly, and then I'll go with the 5, same thing, really slowly, and then put it into the sinus. Now, if you were, let's say you pop through at like a 9, then I would do the same thing. So if you pop through at 9, then I would take maybe the 4 millimeter or 5 millimeter and then push the PRF up. And then I would finally take the 9 millimeter and push it up. But don't pick a don't pick a condenser that's longer than where you actually perforated the bone. I subtract 1 millimeter. So if it does perforate at 9, the longest stopper or condenser burr I would probably pick would probably be an 8. Just to say it's safe where the cutting edges are not being located inside the sinus.
And then just to go back, if I'm using those stoppers, those condensers, and I'm trying to check to see if I'm through the antral floor when I'm actually drilling, you can put that stopper in there. And if your instrument goes all the way up, you're through the sinus floor. And if it doesn't and you bottom out, then you can actually push almost like the old school osteotome approach. And you can try to push and just kind of like green stick fracture or down fracture into the sinus. If you have some of the antral floor already drilled into, sometimes you can just pop right through it. So again, there's multiple ways to get to where you need to go. What Dr. Brisky and myself are going to be teaching here is, some of the more predictable ways to do it. But again, we're always going to circle back to the philosophy of, hey, in your hands, in your practice, what's getting you the results? And so you might be able to take 99% of what we say and then curate your own 1%.
Yep. So here's a picture of it. You can see where it did tense up. It tensed up all the way over to here. And then it actually went up here too. I think this is part of the PRF. So this is part of the PRF little slug right there, and then the rest of that is bone around it. I think we went from up to like I think I went 4 to maybe like 10 or 11 on this one. And here's one at this was a 3-year post-op of this one, maybe 4-year. And yeah, you can see it started to turn a little bit brighter color there. So a new cortex is forming.
And on some of these smaller lifts, I'm just putting PRF in there. And this is not necessarily what we're going to advocate for you guys to do in the very beginning. Do the whole procedure. But, sometimes in smaller lifts, I'm just doing PRF and lifting it. And we're just getting complete native bone formation over the top. So even if you're worried about PRF and not using cortical cancellous, you can still just lift in a small way with just traditional PRF.
Yep, there are definitely several articles that show that too. Just PRF alone will have bone formation. It will. It just won't be as fast, right? Or as dense. So you're going to be looking for more dense. So if you have maybe a lift that, maybe you're at 7 millimeters or you're at 8 and you're like, man, I just kind of want to place a little bit longer implant. Perfectly cool. So if you want to do a vertical sinus at 7 or 8 millimeters and place at 10, by all means do that. Maybe on that one, you can just place PRF. You actually won't really need to place bone with it as well. So part of practice ownership is also being a little bit economical with materials. So sometimes it is nice to use something that's a little bit less expensive. So here's another case. This one was 2 extractions and 2 implants and 1 implant and 1 vertical. So another good day at the office. If you're looking at these types of cases, I get a lot of questions on whether I should do an immediate at the same time or not. My answer is usually no. So look at this bone. You see the bone is here, then it goes up, then it goes over to here, and then it finally rests back up here. This is like a teeter-totter. Everything go up and down, up and down, up and down, right? I would rather enter this area to place an implant if the bone was a little bit more stable. So you should be able to get, with good grafting and good socket preservation, you should be able to get the bone to the level of the adjacent teeth. So the bone on right here can actually go up to right here, right? Because the bone on this side is up here and the bone up here is over there. So in this type of case, I would rather get all of this grafted so I have additional height. And then what if you actually don't have to do a vertical sinus in the end? So in these types of cases, I do choose to do socket preservation to gain some of the height of the bone back, some of the height back, some of the width back. So hopefully your vertical sinus is a little bit easier.
One point I just want to clarify is you can only grow bone back to the height of the adjacent levels of bone.
Yep.
So and granted, I'm going to disclaimer that statement. Without really advanced bone grafting techniques, getting vertical is difficult to do, and that's not what we're talking about today. So making sure both adjacent levels are here, then you can have a really good socket preservation approach, and then come back in later and you'll have more vertical in that scenario.
Yep. So that one, when I really dived into it, there was like no bone here. So I was like, man, I really need to do socket preservation to get some of this back. Thank God we got some of it back. I almost got 4 millimeters. So now we're good enough to do a vertical sinus instead of a lateral sinus. So fantastic. So this one, I placed the one in front of it first, and then I use the Blue Sky Bio and the stoppers as well. So this one bottomed out on, I think it was probably 5 is where this one went through. And then this one, place the implants. You can actually see it's a pretty big lift on this one. I think I chose an 8. It was an 8. It kind of looks like a 10 almost. Yeah, I think it was an 8. Then went all the way up to about 13 or about 10, 11 on this one for the sinus lift. So pretty big increase there. And this was an X-ray of the 3-year follow-up. So we ended up getting this died back just slightly. You'll usually get about maybe 15 to 20% shrinkage of the graft. This one at the 3-year mark ended up at 9 millimeters. And here's the same thing. You can see this cortex, new cortex is being formed here, all the way around it like that. Mark, any questions on vertical sinuses right now?
No, You guys are doing a great
Yeah.
job. This is really good.
Okay, I want to point out a couple of things in some of these kits that are a little bit different. So this kit actually uses water as a hydraulic pressure to raise the sinus up itself. It's also a good technique. For me, this kit, I can literally do a vertical sinus in probably 5 minutes. And I just have gotten so extremely fast. I think it's so predictable, where I'm not getting perforations for the membranes literally at all. It's just a very safe kit for me. This one, I feel like there's a lot of parts and pieces in it. It makes me a little bit more nervous. It's also implant specific, so it's meant to be used with a hyoscine implant. So you just have to do a little bit of extra thinking when you're doing your right, the width of the implant or the depth of the implant, that type of stuff. So this one is a little bit more scary for me. I don't know. I just feel like there's more parts and pieces. I'm a simple person, so this kit was right up my alley. This kit right here by JK Dental, it follows the same rules where you're going to use the stoppers in drilling, just like we talked about. When you see this burr advance is when you stop. Now with that one, you can actually use Nova Bone. Nova Bone's a putty. So what you'll do is you'll go till you perforate the sinus, not perforate the sinus membrane, right? But where you're actually getting rid of all the bone. Then you can use one of the 0.25 xenograft syringe tips, and you stick it in the osteotomy, and you just press, you squeeze, and you actually be able to raise the sinus membrane up just using that Nova Bone. So actually a very simple technique too. With densa burrs or osteodensification, I do see a lot of posts on Facebook, or I do get a lot of text messages like, hey, I placed this amazing implant with Versa. I went from 4 or 5 millimeters all the way up to 10. And then at week 10, usually it's around week 8 to 10, they see the implant fails. And the reason is you're burning the bone. So I definitely always caution people when they're using densa and osteodensification. You have to be really good at providing adequate hydration of the bone so you don't get the bone to burn. It's really good for densifying osteotomy sites in terms of going from like a D4 or to a D3 when you're placing an implant. And I do think it's really good for getting, 2, 3, 4 millimeters of bone height. But going from, 3, 4 millimeters of bone all the way up to 12, it's not predictable. I don't find it's very predictable in everyone's hands, but it is predictable in some people's hands. So it makes me hesitant teaching that specific technique at the Surgical Institute. But Dude and I both do use it, but we are more careful.
I'm sorry, Dan.
Yeah,
Didn't
go
mean to
ahead.
step on.
No,
Can
you're
you
good.
just real quick go over the technique for Versa and Densa? Exactly what kind of not just the quick protocol, but the whole idea behind the concept of this technique.
Yeah, of course. So this burr is meant to be drilled in reverse, right? So it's drilled in reverse. It's meant that's like this very quick pumping motion, and you're gonna be drilling with a ton of water because you're going to be densifying you're going to be, as the burr turns in rotation and counterclockwise, and you're pressing, you're going to be densifying the bone and pressing it at the same time. So your hand's going to be pressing it up, up, up. So you're forcing the burr to densify the bone, and you're forcing the bone apically with your hands. And in doing so, you're really like you're like crunching the bone. You're compacting it. You could accidentally burn it or remove all the blood supply that's inside the bone. So that's why I always try to scare people a little bit when I talk about this method, because I want them to do a really good job placing it. So usually it's around 800 RPMs is what you're going to be running that in, and reverse with the pumping motion. After that, you actually put bone inside the osteotomy, and then you run it in reverse, usually at 100 RPMs again, and you're just sending the bone up is what you're doing. And then you're placing the implant. It does get really good stability. It does. It's a very good, quick method to do a small bump. But if you haven't used it a bunch, just be a little bit hesitant on it and make sure you're getting the right training for it.
What we're hearing from people is that they're over advancing it, because there's no generalized stopper system. And so you can tear the membrane more easily. And then two, to kind of overcome some of that overheating, which you can do, and I know some docs who do it this way, is they just put saline in the fridge. And then when the surgery comes time, then it's extra cold saline, you pull it up in your monojet syringes, and you're having an assistant really cool down things. So every time the burr comes out, irrigate, really cool down stuff if you're going to use the Versas. But the thing is, I mean, you know, in our estimation, it's not as good of an approach for what we're talking about today, which is going to be, you know, sinus elevations. And then two, it's a very expensive kit. So it doesn't tend to get the job done as well as some other options that we have.
I've never seen, so when you get into implant failure with osteodensification, it's usually a really big failure. So that site where you had that 4 millimeters of bone, if you burn that, you're not getting another one in there without grafting it and probably doing a lateral sinus. So that site might be destroyed now. So that's why I'm saying it's good for smaller bumps. I really do think so. It's great for it. But is it as predictable when you're going a little bit further, maybe from 4 to 10? In my hands, no. Maybe in some people's hands, definitely yes. But I just caution people, because if you have a scenario where you do burn the bone, this might not be a potential site for an implant now.
Thank you. Thank you for that summary. Makes a lot of sense.
So let's see those ones. Yeah. Do we want to jump into laterals today?
I think we were gonna hold off on laterals until, so we can have a whole, you know, a fresh webinar session for them and do justice, because we only have about 6 more minutes left. That would be just a quick intro, and we would leave people unfulfilled. I think that's a really nice natural place to stop. Anybody in the audience, we have a lot of people actually that are watching this live. If you guys want to hit the chat, if there's any questions that you want to ask the experts here over the next 5 minutes, we could do that.
Yeah, and remember guys, like there's a lot of good ways to do this. There is for vertical sinuses. You could still use osteotomes. Perfectly okay. I do think people get headaches after with all the banging. You can use Versa. Just be careful, please. Part of education is making sure people don't get into trouble, and I'll do everything in my power to make sure people don't have referrals out for the times they do get in trouble.
So without going down too much of a rabbit hole, because I think many of us that have gone down the road and done vertical sinus lifts have tried the Versa technique. So if you could just maybe, like when you say it's successful in some people's hands and not so much in others, what are people doing? Getting too aggressive with the pressure, or not using enough water? Like, how can we increase the likelihood of success using the Versa or Densa-Burr method?
I think what happens is, you know, once you get proficient at anything, you go faster. You know, they say your highest complications are in your first 50 implants, and then from, you know, 100 to 200, or maybe not that, maybe like 500 to 600, because now you're experienced enough. You start to cut a few corners, you go faster. So I think what's happening, and this is just, of course, you know, like me playing detective, is people are getting very proficient and fast. They're faster in and out of certain procedures, and now they're just pushing too hard, getting down to the finish line too quickly. So I'd say maybe just subscribe to exactly how you need to use the Versa burr, and really slow, and it could be very successful still.
Yeah. Well, good stuff, guys. I really appreciate you taking the time to educate us all in vertical sinus lifts. The next one that we will be doing then naturally is going to be a little bit of talk about lateral sinus lifts. We'll have a whole hour to do that. And you guys stay tuned, and we will get that scheduled. So we'll get Ashley Hirschfeld back on here to close this thing out. And we'll bid you guys a fond farewell until the next clinical webinar. Ash?
Mark, do we want to answer this one? Yeah, like
oh, sure.
do we want to answer these two? Okay.
Go
So
ahead.
first question we got is, can you provide a summary on membrane and graft techniques for success? Do you find it as successful to get primary closure? Cool. Yeah, really good question. So grafting with vertical sinuses, I like to use You can use, there's plenty of different ways to do this. Now you can use allograft, like a 50-50 cortical cancellous blend. You can use xenograft just for it. And you can use a combination, like do 50-50%, do 50% of it cortical cancellous and 50% of it xenograft. I'm more in that ball camp of doing 50-50 because the xenograft is going to stick around for longer. So it's more space maintenance. So it'll leave a little bit of additional time with decreased resorption of the graft for it to stabilize and not shrink as much, right? So I'll commonly use that. Membrane, when I'm doing vertical sinus here, I don't use a membrane. I'm just using a quasi membrane, which is a piece of PRF, right? Now, if it's an immediate, then I would use a piece of pericardium, right? A piece of pericardium around the site and with the grafting. But as far as membranes, I don't use membranes for the vertical technique. I just use a piece of PRF.
And the one thing I'll add to that is as you're drilling at a 50-50 on your traditional burrs, you can also, when you take them out, you'll see there's like red bone on there. I have a little dish of saline, so I'll just save my autogenous harvesting, mix it in with my graft, and I'll stick it up into the sinus as well. Because then you get your osteoinductive, osteoconductive type of approach to the bone graft. And then secondarily with the grafting, I just use my Maxius bone graft. We got like really good deals and they're a reputable company.
And you can also, Doc, you can use some antibiotic to hydrate your grafts too. I always hydrate my bone grafts with antibiotic, no matter what the scenario is, whether it's a single sinus or if it's a full arch. I'll hydrate it with 3% gentamicin or a 5% metronidazole, just to give myself a little bit more running room with the sinus. But as far as primary closure, so you can put I think that'd be a question based on, let's say there's 4 millimeters of bone. If I'm doing a full arch, I would probably do the vertical sinus, but then bury the implant. I wouldn't load the entire case to be safe. But if it's a single tooth and you have at least 4 millimeters of bone and you're getting stability is, anything I call stability with this vertical sinus, like 30 to 35 Newton centimeters or above, then I would put a healing abutment on. Anything below, I would do primary closure.
And then just to add on to that, the healing abutment you choose, get one that's a wider diameter than the diameter of the implant. So just in case there's trauma to it, it doesn't push into the sinus because the diameter of the healing abutment is wider than your implant. And then primary closure, yeah, if you put a cover screw on there and you're doing, an immediate site, you got to wait for all that to granulate over. So ideally, if you have just a traditional incision, you should get primary closure over a cover screw. But in that situation, you may want to consider, if you might do a cover screw based on the density of the bone, you might want to do a slightly lingualized incision when you go to enter, because when you suture it, you don't want your incision line being over your cover screw. You want it being palatal to your cover screw. So then you're going to have more closure and more bacterial protection over your implant.
Yep. Oh, Jeremy, what's up, man? Hey, I need to text you back. I think you text me on Monday. I'll text you back after this. But Jeremy, let's see. What about just drilling to sinus floor, drilling slightly through it and squirting nova bone, or just drilling up to the sinus floor, tapping, drill, green stick fracture, and then squirting nova bone? Well, so, I mean, if you're going to just drill up to it, as long as you have that 7 millimeters of bone, right, just do it, just place the implant. But green stick fracturing it, you could do that, right? For me, if there's 7 millimeters of bone or 8 millimeters of bone, I'm just going to drill that bone away and place the implant. I don't see the why I would want to do the vertical sinus lift. I feel like it's either a sinus lift or it's not a sinus lift, right? That's how I'm qualifying it. I just don't think there's like a subcategory. Could you do it a different way? For sure, you could do that. You could do a green stick fracture to place the implant all day. But I think in the beginning I was a little bit more hesitant because I didn't know if I fractured it or if I went past it. So I would just try to follow more of like a strict protocol when you're going to do a sinus lift, when you're not going to do a sinus lift, and just kind of stick with it.
If you're going into the sinus, have a membrane, have a kit. So the question ended with, do I need a kit type of scenario. If you're going to do sinus lifts, if you're going to do anything like that, have a kit on hand because you're going to need it. And eventually you do enough of these, you're gonna make your money back on the kit, very quickly.
Yeah, 'cause especially full arch, right? What if you thought you were going to do an implant? That was just the implant. Now it's an implant with a vertical sinus because you had to take a little bit more bone away, right? So definitely have that kit on deck. So drilling 2 sinus floor, but right, if you drill just 2 sinus floor, remember you can still have your implant spin. So I have people say to me a lot of time, I'm gonna drill to the sinus floor, then I'm gonna place the implant and have the implant bump up the sinus. But you still have that chance when you're placing the implant and when it's rotating in that it hits the crestal floor and then the implant starts spinning, right? So we hear this all the time. So just make sure you are prepping that crestal bone and you are engaging it, or you're staying shy of it, right? But it's hard to really engage that cortex without it either losing without it like losing stability, honestly. Some people say, hey, I engaged the sinus floor, then I see the x-ray, but you were really just close to it, you weren't engaging it.
And then Doug has a question about, what do you do if you perforate the membrane? Do you cover with meds, and why? So I would say in this scenario, it's going to depend on what type of vertical you're doing, and it's going to dictate whether or not the tear means anything. So if it's just one where, you're only going for like 2 to 3 millimeters on the lift, and you just pack some PRF in there and just allow that to kind of, tent in there and cover up the small little perforation, then just do a PRF lift. Don't shove cortical cancellous and particulate up in there because it's going to be more abrasive, and then place your implant. If you're doing like a smaller lift, a larger lift with the smaller level of bone, yeah, at that point, if you tear the membrane, you might have to abort your vertical, and then you may have to go into a lateral approach, go in there and elevate around the tear, and then use like a bio-exclude to seal up your small little perforation. Now that conversation will happen on the next webinar when we cover laterals. And then for meds, Dr. Brisky, you want to kind of field some of this because I know you got some thoughts on.
For sure. So in the I'd say with a lot of these cases, until you get quite a few of these cases on your belt, don't try to go in and do the lateral to elevate it up, because it's actually technique sensitive. Being able to remove the amount of tension that's around the membrane to allow you to find where that tear is and pull it up without making that tear bigger, I'd say. So when you get this type, if you're doing a bigger lift and you do see a darkness, like a black hole up there, right? Or you have the patient, you plug their nose and you say, breathe through your nose, and you see some bubbles come out of there, or you can hear the air. You can actually hear the air come through when you get a perforation. I would just close it up, call it a day, stick a piece of PRF up there, and then put a small piece of collagen plug over the top of that osteotomy, and just get primary closure to close it up. Now, if you do have a perforation like this, I always give my patient the same sinus guidelines. Those sinus guidelines are to be on a daily allergy medicine for 1 month, like an anti-inflammatory. So any allergy med, you could do Benadryl, you could do over-the-counter Kroger, or right, in terms of the antihistamine, they're all going to have the same function. Then I would also advise them to stay on a Sudafed. Sudafed's a little tiny red pill behind the counter. You have to sign your name saying you're not going to make heroin out of it, right? That little circle one. I think the dosage is 15 milligrams for the small one, and then have them do that daily for 2 weeks, and then as needed after that. And you tell the patient, hey, you're going to be on this to lower the sinus inflammation. The Sudafed is going to be as needed basis. So as you feel sinus pressure, or right, then you can take that medicine to bring it down. As far as medications for antibiotics, I would do amoxicillin or Augmentin. So usually I'll do an Augmentin type of drug for 10 days. And if I'm not doing Augmentin, if they're allergic, then I would go towards a Z-Pak and metronidazole, both, because technically that's the new guidelines. We're not using Clinda because Clinda has a black box warning on it. I'd recommend doing a Z-Pak plus metronidazole to keep textbook. Yeah.
Well done, boys. Way to field those questions. Thank you for recognizing that they were there. I didn't even see them. Ashley, you want to close things out for us?
Yeah, thank you guys so much. We'll go ahead and work on, I'm already messaging with Chris on the other side to get the next one scheduled. Use that second link in the Zoom chat to get your CE. Again, if you are in our Zoom live, that's where you get the live CE. Otherwise, this will be posted in our webinar section of DSN within the coming weeks.
Cool.
All right, DSN, Dr. Dune, Dr. Brisky, thanks again so much. Thank you, Ashley. We will talk to you guys at the next clinical webinar, and have an awesome day.
Cool. Awesome.
Awesome.
you.
Thanks, guys.